Okay. Good evening, everybody. Welcome. We're going to seek to get started. I know that parking is a challenge. We should have assumed with it being June that there would be a graduation, but I understand that there is a graduation at the center in the square. So hopefully we can continue to welcome people in. We've got great attendance here at the Kitchener Public Library and as well online. So I wanted to take a moment to welcome our community leaders, distinguished guests, and those that are joining us virtually through Slido. Thank you. Our third town hall hosted here at the Kitchener Public Library in about 18 months. And what's really special about tonight is we're doing it in partnership with the Region of Waterloo Paramedic Services and the KW4 Ontario Health Team. We're proud to be a member of the healthcare system alongside these partners and others to provide the right care to the right patients at the right time. We're honored that you've chosen to spend your evening with us, especially on the night of Game 6. So I will give Oilers and Panther updates as we get into the Q&A, I promise. We want to continue the important work of building the system of care for our families, for our neighbors, and for our friends, and what they need today and also for the generations to come. Tonight, we're proud to host this event in partnership with our Ontario Health Team and Paramedic Services, and we will have everybody join us on stage at the end so that we can learn together, you can ask questions and receive answers, and we can explore together new ways to support the health and well-being of all those who seek care in Waterloo Region and beyond. So here are our panelists for tonight. We have Ron Gagnon, President and CEO of the Waterloo Regional Health Network. We have our co-chairs of the REN board, Sandra Hanmer and Tim Rollins. We have Chief John Ritchie, Chief of Region of Waterloo Paramedic Services, and Ashnur Rahim, who is the Executive Director of the KW4 Ontario Health Team. So our agenda for tonight, after acknowledging the land on which we work, live, and provide care, and we've got one of our REN team members here, Elizabeth Ferguson, to do that, we will have the privilege of hearing from Elder Mayingan Henry, who is a partner and strategic advisor to the hospitals. We'll then move to hear updates from the 3 health system partners and engage in discussion with you. So I'd like to welcome up to the stage Elizabeth Ferguson. Elizabeth is the Executive Vice President and Chief Operating Officer of REN, and she will acknowledge the land that we are gathered on today.
Thanks, Sarah. Good evening, everyone. Waterloo Regional Health Network acknowledges that we gather, work, and heal on the traditional territory of the Haudenosaunee, Anishinaabe, and Chinanton peoples. Our healthcare team and community provide health services within the Haldimand Tract Treaty of 1784 that granted 6 miles on either side of the Grand River to the Haudenosaunee Confederacy. As part of reading a land acknowledgement, it provides a real opportunity for personal reflection. And the personal reflection I want to share with you tonight is really how the journey of truth and reconciliation has been influencing the clinical services planning we've been doing at REN. So things I've learned. Hospitals are institutions that hold immense influence over the health and well-being of communities. Beyond providing clinical care, they are also symbols of trust, safety, and healing. However, for many Indigenous peoples and other marginalized communities, hospitals have historically been places of trauma, exclusion, and systemic harm. Understanding this truth is critical for hospitals as they reflect on their roles in society and plan for a more inclusive, equitable future. Truth and reconciliation are not peripheral to healthcare. They are essential for restoring trust, improving care, and shaping clinical services that serve all patients with dignity and respect. Since joining Legacy Grand River Hospital in April 2024, and now in my role at Waterloo Regional Health Network, I have learned that reconciliation begins with truth. In Canada, the Truth and Reconciliation Commission has documented the deep and lasting impacts of colonialism, including the role healthcare systems played in the forced assimilation, neglect, and abuse of Indigenous peoples. Many hospitals, whether through inaction or complicity, contributed to health disparities and the erosion of Indigenous healing practices. Failing to acknowledge these histories perpetuates harm. Hospitals must recognize their roles, past and present, in systemic racism, medical experimentation, and unequal access to care. A public institutional commitment to truth-telling is the foundation of reconciliation and a necessary step towards reestablishing trust. Over the past year, I've had many opportunities to listen to the experiences of Indigenous peoples and to reflect on how we at REN can do better. Personally, I've learned that reconciliation is not only retrospective, it demands forward action. For Waterloo Regional Health Network, this means embedding cultural safety, humility, and practices into everyday patient care. We've made a commitment to train our staff to understand how intergenerational trauma affects health outcomes and healthcare experiences. We know that our interactions must be grounded in respect, listening, and a genuine willingness to learn from patients' cultural perspectives. By actively including Indigenous knowledge systems, language, and ceremony in healthcare delivery, we can begin to make care more responsive and affirming for patients who have historically been marginalized. Reconciliation includes confronting the ongoing disparities in healthcare outcomes and access. Indigenous patients, for instance, continue to face higher rates of chronic disease, mental health challenges, and mortality. These disparities are not inevitable. They are a result of policy decisions, resource distribution, and institutional bias. A reconciliatory approach to care planning must involve re-examining how services are allocated and how hospitals provide community health needs, and how we prioritize those. At REN, we are evolving to meet the needs of our communities, and future clinical planning must be grounded in reconciliation. This includes meaningful engagement with Indigenous communities in the design and delivery of services. Consultation must be more than symbolic. It should be led by principles of self-determination and partnership. Health services must be co-developed with Indigenous leaders and reflect community values, priorities, and health practices. I have learned the physical and cultural spaces within hospitals matter. Creating spaces for ceremony, Indigenous art, smudging, and family-centered care can make hospitals feel more welcoming and respectful for our Indigenous community. Investing in Indigenous staff, leadership roles, and culturally aligned models of care is also a concrete expression of reconciliation in action. At REN, we are fortunate that we have an Indigenous employee circle and an Indigenous advisory circle who are generously guiding us, teaching us, and working with us on this important journey. We extend our deepest gratitude to our Indigenous partners who support us in honoring the ceremony of their culture. Whether through the lighting of sacred fires, the powerful rhythm of drumming circles, or the cleansing practice of smudging, we appreciate the healing and connection in our shared spaces. For me, these ceremonies have been profound gifts of trust and cultural sharing, and I'm personally humbled by this journey. Truth and reconciliation are more than moral imperatives. They're strategic priorities for the health system that serves to seek the diverse populations with excellence and compassion. By facing the past with honesty and planning the future with inclusivity, hospitals and the health system can contribute to healing not only for individuals, but for communities that have long been underserved and harmed by the healthcare institutions. So thank you.
Thanks very much, Liz. So tonight we're honored to have Elder Mayingan Henry join us and bring a teaching. Elder Henry is an Indigenous knowledge keeper and the former elected chief of the Chippewas of the Thames First Nation. As I mentioned before, he provides strategic leadership to the hospitals in Waterloo Region, to the University of Waterloo, and has for Conestoga College, the Ontario Provincial Police, and others. Elder Henry every day works to foster a reciprocal and respectful relationship with Indigenous individuals and communities. So thank you for being here to offer a teaching for us today.
Take the mic down here. Honey, Bujo, Sego, Nancy. I was thinking about this when I seen you all sitting here. Our communities were at many times offering our community to come back together. In a traditional manner, we would be sitting in a circle, and the circle that we sit in carries all of our friends, our supporters, the people that we grew up with, our family, all the people that are significant to us. And when we sit in the circle, it just makes a more powerful opportunity to feel the unity that exists and should exist. Inside that circle, though, there would be a fire. A fire is very important for life in general. The fire keeps us warm. The fire reminds us that the daytime hours are for us to do our work. And it reminds us of the heartbeat that we have within our personal being when we sit around the fire. And those of you that may go camping probably know what I'm talking about, because it's such a good feeling to be outside and around that fire. So in our way that we always did our meetings, we would bring the fire and sit in a circle. So I'm gonna, because it's hot outside, I feel like a fire. But anyway, just use your imagination for a moment. Rather than sitting in the rows that you are, imagine sitting in a circle. We would call the community together, because community comes with experience, generations of relationships that they've built, and most of all, the love for their community. When we sit in our circle and we talk about events in our community, we all have opinions and strengths that we can add to it. And so the elders would always ask that we would hear our opinions and be strong about what we think is necessary for our community. And it's nothing really different from what we're doing tonight. We're here tonight talking about something very important, our health. But when we sit in the circle, we would bring the elders in, because they've been on this earth for a long time, and they have some wisdom to share. And so now that we're sitting in a circle, I'd like to introduce you to an elder that walks into the circle, and the elder would be as, I guess, if you look at the elder's faces, you can tell that there's experience there. There's love in his eyes, and there's strength in his teachings. And so what he would like to do tonight is to bring you all together and say that there is an important piece of information that we'd like to pass on to you. You know, those elders, they know that life, the circle of life, is sometimes very short, but sometimes it lasts for a long time. If you think about the circle itself, you're born as a child, and you move into your teen years, where sometimes it gets a little crazy during those times, but then you move into the adult years, where you have your families and your work, and at one stage you'll move into the elderhood of life. And as that circle moves into a complete circle, we feel all of those things that are in the middle. And so tonight, we're talking about a very important issue, our health. Our health is something that we can really help to understand if we look at it from a holistic point of view. So our elders and the elder that come into the circle tonight wants to let you know that when you're born in this world, you're born in water, inside the womb. The water that surrounds the baby as it grows in the womb. It feels that need for water, the strength of that water, the nourishment of that water. And then the big ceremony that takes place is when the water breaks and the child comes to the earth, and for the first time meets our mother, the earth. It reminded me of a time when I was young. I used to like to go fishing, and so I would go on the water in a boat, and I would feel that there was something about that water that made me feel at home. And maybe it was my relationship to my mother in the womb of my mother. And I would be in wonder, though, of the things I didn't know around me. I could look into the water, and I wouldn't know what's under there. sometimes it'd be a little scary to think about what could be under there that I don't know. And even when you're swimming, if you ever have a fish go by your feet or something like that, it kind of makes you jump a little bit. But the things that are in that water are so necessary for life. And as I was in the water fishing, I started looking toward the land. And as I looked toward the land and the shoreline, I could see things on that land that was really important to me that I didn't really notice before. I could see the grass, and I could see the plants, and I could see the trees, and I could see the animals. And it was so important to recognize how important that is. So my next stage of life, I was able to walk on the land with more vision. And as I got a little older, I noticed those beautiful trees that were so strong and so tall. And I would look up in those trees and I would see the branches be kind of holding their arms up, almost like they're praying a little bit to create, they're looking up to something in the skies. And I got to raise my head and to see what's up there. I noticed something really important. I seen these birds that were up there. These birds, in all of my amazement, were so beautiful to look at. They would fly and I would watch them. And I would wonder about them, their purpose and the things that they were trying to teach us. And I found out that they had a very important role in our understanding of the life that we live. And so I even went a little beyond that. One night I was watching the skies in the evening and I got a chance to see the stars. The stars, if you look, it's so amazing to me still today that those constellations that we see up there and the stories, our history is written in those stars. They say that even our ancestors are within those stars. And we look at those stars in awe at night and just tell our stories, and we can see those shooting stars and we can see the Big Dipper and all the other beautifulness that's in those stars. And I started thinking about, it's similar to life. We go through that whole process. And then beyond the stars is back to our Creator, how important that is for us to have that complete cycle of life. But when I think about why it's so important to know that, is because our health, our mental health, our physical health, relies on this beautiful world that we live in. It's such an important element of our safety, of our health, and the strength we have as the human beings on this earth. So if we can put that into a concept of life today, to be able to keep our beautiful earth healthy, our mother, we call Mother Earth, as respectful and sacred as possible, I think we could see a better outcome for all people on this earth, mentally, physically, emotionally, spiritually. To have all those, I think, is the remedy of good quality healthcare. And now that I've been working with Ren for some time, the concepts of that is really what I'm hoping to achieve in this community here as we build this new and improved and stronger hospital community. I think with the Indigenous knowledge in perspective, we can start building a framework that's going to be a wonderful experience for all. As we all go through the life cycle, this hospital will play a very important role into all of our healthcare and the things that we do in our community. And so that's how these circles operate in that manner. And since we've been working together the last couple of years, I've noticed that there's been a strong commitment to a reconciliation, trying to understand the past that wasn't very healthy for Indigenous people. Even today, we still follow I guess some of our elders are still scared to go to hospitals because of the mistreatment that they've had in the past. But Ren has proved to me that they want to move forward with a better plan and better health care for not just Indigenous people, but all people. But recognizing Indigenous people had been left out of that healthy framework for a long time. So at a recent meeting, well, before that, we put together a community advisory council, more of a thought council that we can all share our thoughts for going forward in this community. And it's been a wonderful experience. We have a number of talented people that sit on this advisory council. As Ren sits with us, we explore opportunities. And we've only started in December of last year with this group, but I think we've moved so far ahead already. Now we have identified Indigenous healthcare workers at Ren with an Indigenous employee circle, which really helps us along with the path. We have ceremonies at the hospitals now, and we have partnerships, even with Cambridge. We work together with them quite well. So I've seen some great movement in the last little while, which I guess inspired me to go visit a board meeting. And at that board meeting, I thought that this eagle feather that I'm holding reflects that beautiful bird and strength that's in the sky. If you ever see an eagle, it's such a beautiful sight to see. But for Indigenous people, the highest level of honor that we can bestow on anybody or any group is an eagle feather. And because of how we've been treated and how important it is for Ren to move forward in reconciliation, I offered this eagle feather to the board, and it was to remind them of this road that we're on, this road of reconciliation and strength that we can have. And as we work forward and look at this eagle feather from time to time, we'll always remember the importance of building good relationships, even through different people that might work at the hospital and the different departments in the hospital, so that they know that there's been a contribution from the Indigenous people to help supply good health care, and even bringing Indigenous healthcare systems like traditional healing methods and smudging and the other things that we do in healthcare. So the eagle feather, I'm so honored that they accepted it, and so now they can look at that feather and all the things we talked about in our opening about statistics of Indigenous health. This will remind us that we still have to put that as a prominent part of who we are at Ren. Not just, like I said, for Indigenous people, but all people, but because Indigenous people's health is still lacking by up to 15 years less than mainstream today. Our life expectancy is still, has to improve. And so with the outcomes of this hospital's priorities, with the eagle feather to help them understand and remember, I think we're going to move forward together in a good way. So that's what I wanted to do, to bring you to this circle this evening, just to remind you of the healthy relationship that it has been created, and even stronger as we go forward. So you can go back into your rows again, and you can sit there and listen to the rest of the presentations tonight. But just being here tonight is someplace we couldn't even be a number of years ago. We weren't even thought about at town halls or at priorities at hospitals, but now we are. And I want to thank you, the community here, to have the patience to understand it's not Indigenous people are getting more. It's just we're trying to get up to the standards that all Canadians face. And that's kind of what I hear sometimes when we invest in First Nation people. Well, why are you investing in that one ethnic group? Well, it's not so much that we're giving more to that group. We're just trying to balance care for all people. And we've been kind of below that line for some time. So any investment that we put into it now, it starts to even out the standard of living for all. And we appreciate that so much. And I think you as a Canadian would be even more grateful as all people live in good health care and equality in this country. So I'm going to close it there, but I want to thank you, and I want to thank Ren, the staff, the leadership of Ren, and all the people who made this possible for our community. We say in my language, Chimigwech. Thank you very much, and it's been an honor to come and join you this evening. Miigwech, everybody.
Okay. Thank you, Elder Henry. Your gift of knowledge, of time, and bringing learnings to us is something that we're grateful for as we work together to ensure that the care we're providing today and building for tomorrow is inclusive, welcoming, and embeds the traditional ways of healing for the patients we serve. So now that we've opened in a good way, I do want to take a moment to introduce myself. My name is Sarah Farwell, and I'm the Vice President of Strategy, Communications, and Public Affairs at REN, and take a moment again to welcome those who have joined us in person here at the KPL, and we've got about 200 online with us tonight, so grateful that you're spending your evening with us. Caring for our community is the reason we are here, and it requires an entire system and supports to wrap around the patients. I'm pleased now to welcome Ashna Rahim, Executive Director of the KW4 Ontario Health Team, to share more about the healthcare landscape in Waterloo Wellington. Welcome, Ashna.
Thank you so much. It's always so hard to go after Elder Henry. So good evening, everyone, and thank you for allowing the KW4 OHT to share an update about the great work underway in the region to support the healthcare of our communities. As Sarah said, I'm Ashna Rahim, and I'm the Executive Director for the KW4 OHT, and I'm honored to take a few minutes to really talk about our healthcare landscape in the region, share some key government priorities, and spotlight some of the services and collaboration work that's happening across the region. So to begin with, as you all know, or you may know, we're part of the Waterloo Wellington geography, and this is a very diverse geography. It serves over 830,000 people, and that includes urban and rural populations. It's really fast growing, and it's multicultural. Our healthcare system has 3 Ontario health teams in the Waterloo Wellington region: the KW4 OHT, Cambridge North Dumfries, and Guelph Wellington. And the ultimate goal of all 3 of our OHTs is to create local, organized, and integrated care pathways so community members can access the care they need in a seamless and efficient manner. Our OHT, the KW4 OHT, includes the beautiful cities of Kitchener and Waterloo and the townships of Wellesley, Wilmot, and Woolwich. We serve over 530,000, about 830,000 people, and we work together with over 43 health and social service partner agencies, working with family doctors, mental health and addiction service providers, the hospital, and community organizations. What's unique about our OHT is the incredible collaboration that occurs. Everyone comes to the table with a shared vision of a more connected and equitable system. We're also intentional about partnering with our Indigenous and Francophone communities and organizations. Elder Henry spoke about the relationship between Indigenous people and healthcare, and it's very important that when we approach this relationship and the reconciliation process that we're thoughtful and we approach it with the cultural safety and accessibility priorities that it deserves. Together with our hospital, primary care, and community organizations, we're moving forward to create a more integrated, team-based, and person-centered care model. Last year, the OHT presented its first 5-year strategic plan. This plan was developed through engagement with over 1,400 individuals. And the areas of focus that the community told us they wanted the OHT to support were working together with the community to build care pathways, really co-designing it together, accessing care when you need it and where you need it, and focusing on prevention. How do we keep people from getting sick? And how do we keep people well and thriving in the community? Finally, understanding that not all communities are the same. People face different challenges related to the social determinants of health. And these factors, food security, housing, income, friends, and supports, must also be taken into consideration when we talk about health and wellness. This year, the Ministry of Health has confirmed a few key priorities that the OHT is focusing on. At the top of the list is primary care modernization, really expanding primary care for unattached patients, those who don't have a primary care provider. We know that our communities in the Waterloo region don't have enough doctors and nurses, and we're working with the Waterloo Chamber of Commerce, the hospitals, and the universities to attract more healthcare providers to our region. we're working with our primary care network to create a plan to achieve the government's goal of 100% primary care attachment by 2029. And we're doing this by trying to develop new interprofessional primary care teams that free up our primary care providers' time because others within their team can see individuals for the most appropriate care they need. We're also working with Healthcare Connect, which is an initiative led through home and community care to support those looking for primary care providers. So if you're looking for a primary care provider, you can go on Healthcare Connect and they will help to find a primary care provider for you. We're also looking to strengthen and access navigation services, especially for those who are unattached. In partnership with the Regional Cancer Center at Rennes, the OHT is identifying neighborhoods with high unattachment rates and poor cancer screening rates to determine how we can best increase education and awareness and improve early cancer detection. The second priority that the government has is chronic disease management. This includes chronic obstructive pulmonary disease, diabetes, and congestive heart failure, for example. The goal is to identify individuals at risk for these diseases and proactively support them to reduce their risk and keep them well. So, for example, the OHT has supported programs that focus on healthy eating and exercise because we know that those two components can reduce many of the risk factors related to chronic disease. And the OHT is working with our community providers to ensure that individuals who are at high risk can access these services in a timely way. Over the past few years, the OHT has worked with partners to develop initiatives aimed at better supporting primary care providers and their patients in the community. For example, the introduction of the Rapid Access Clinic, which is a partnership with the hospital's Prevent Clinic and Community Health Caring Primary Care, supports individuals with high emergency department rates. Let's try that again. With high emergency department visits rates for primary care issues that should have been managed in the community. Together with the Prevent Clinic at Rennes and the Community Health Caring Organization, they've been able to see over 523 patients in the last year, a savings to the healthcare system of over $230,000 a year. And they're preventing hundreds of unnecessary emergency department visits. This is just one example of how the incredible OHT partners are working together to create better access to primary care. We've also introduced community agencies into primary care offices. Community Care Concepts, Community Services, works with over 32 physicians at the Boardwalk to provide their patients with access and navigation to community services, saving physicians countless hours and time trying to help their patients themselves, and therefore being able to see more patients. One of the other priorities that the government has really focused on is a digitally connected care system. We've been working with our primary care providers in the hospital to support the uptake of different digital tools across the region. For example, online appointment booking allows you to be able to book an appointment with your primary care provider online rather than waiting on the phone to speak to someone to book an appointment. We've also seen participation in a research project with 4 other OHTs across the province and the University of Toronto to determine the value of AI Scribe in the primary care office. Some of you may have noticed this when you visit your primary care provider, whether they're using an AI Scribe to capture your interaction and create notes. This gives him or her more time to listen to you and hopefully allows for better patient-provider interaction. The region of Waterloo is rich in its multicultural tapestry and is home to many different communities. The OHT is working with partners to help identify some of the challenges and opportunities to improve health services so all of our communities, regardless of race or ethnicity, have access to the best care. We're doing this through a variety of different partnerships and tools. For example, our Community Advisory Council acts as a network of ambassadors for the OHT and reaches out to different communities to ensure all voices are heard in the planning and development of different programs. Recently, the Community Advisory Council met with the hospital planning leaders to advise on how best to engage some of our priority neighborhoods and rural communities as we consider the new hospital build. Over the next 12 months, the OHT will continue to work with our Community Advisory Council and others to ensure that all communities are engaged in regional planning, working alongside our primary care network to meet the government's goal of 100% primary care attachment, and focusing on keeping our communities healthy and well. We'll also continue to work with our mental health and addictions providers to ensure that those services that are so difficult to navigate can be accessed and improve care for those in our community with mental health and addictions health issues. Certainly, if you're interested in learning more about this work, feel free to visit our website or come and speak with me at the end of the presentation. Thank you so much.
Thank you, Ashner. We extend our gratitude to you and the members of the KW4 Ontario Health Team for their commitment to integrated patient-centered care, which has strengthened collaboration between hospital, primary care providers, home and community care, and other essential services. By working across sectors, we're building a system of care so that patients receive seamless, coordinated care that meets their individual needs at each stage of their journey. It is my honor now to introduce our next guest, Chief John Ritchies. John is the Chief of Region of Waterloo Paramedic Services and a dedicated leader committed to advancing emergency medical care in our community. Paramedics deliver high-quality, life-saving care in the field, often serving as the first point of contact in critical medical situations. They are highly trained professionals that assess, stabilize, and treat patients on-site and during transport, ensuring continuity of care en route to the hospital. Through close collaboration with emergency departments and our team at REN, paramedics help streamline patient handovers and support effective integrated healthcare delivery. Please join me in welcoming Chief John Ritchies.
Good evening, everybody. Thank you so much for having me here today to represent the Paramedic Services team at the Region of Waterloo and the broader corporation at the Region of Waterloo. We're very excited about the ongoing partnerships that we have with both REN, Cambridge Memorial Hospital, and our local Ontario health teams. We, as people know, the progress of paramedic services has been a fairly rapid one in the last 40 or 50 years. When I started as a paramedic a long time ago, the term paramedic was new in this province. And in the last 30 years, it has become a name and a symbol that exhibits trust for people who need to access the healthcare system, you know, when they're acutely ill or when they're struggling with how else to access the healthcare system. And, you know, our paramedics, their scope of practice over the last 30 years has grown leaps and bounds as we strive to meet the service demands of our community and the ever-growing changes that our community has. What I thought I would do is share with you some exciting changes that are coming into our system that we think will better position us to support our community in their time of need for healthcare, and then also do a big shout out to our partnership with both REN and Cambridge Memorial on some real amazing system improvements that have occurred in the last couple of years. See if I know how to work this. There we go. Okay. So just to give you context, we are a fairly large paramedic service in the province of Ontario. We are in, you know, probably one of the top 8 in terms of size of paramedic service, in terms of the geography that we serve and the call volume that we serve. You can see there that there are, you know, rough numbers in terms of the 911 calls that we service to date. 26,000 so far this year as of last week or the week before when these slides were created. And then in 2023, you can see it was just over 60,000 calls, and then that increased in 2024 to 63,000 and change. And those are call volume increases that we are seeing sustained over time. And that is a function of a lot of different factors. Ashmore brought up the social determinants of health. We know that that is a factor that drives 911 call volume, aging populations, aging demographics, and changing demographics as people live at home with more chronic health conditions. That tends to drive up 911 call volumes. And so that demands that myself and my team, we have a team of 400, of which about 80% are frontline paramedics, but our team is dedicated to continually improving our responses so that we meet patients where they're needed, and we focus on high quality, compassionate, and person-centered care. This picture you see up here is just one example. This was taken on June 4th when we welcomed 47 paramedics to our team, which was the highest recruiting class we've ever had in the history of the region. And you can see, the picture's hard to see, but you'll see that there's some really bright, young, very young, shiny faces there. And they're all really, really dedicated to supporting our overall mission to provide really compassionate care. And we're excited to see what they can bring. We've hired a ton of paramedics over the last couple of years, and we will continue to do that with the support of council and our corporate leadership team as we build our system to be future ready. Which actually brings me to the next topic, which is, as everybody knows, at the Region of Waterloo, we have a Growing with Care strategic plan. And our entire business model for paramedic services, our master plan and our annual business plan is anchored in that Growing with Care strategic plan, in particular with two anchors. One is making sure we're future ready and resilient, and the other is making sure that we deliver equitable services and opportunities to our community. And we think that our plan achieves that. In particular, you'll see under other response roles, this is becoming a rapidly growing sector of what we deliver to the community. And that is, it's not just about responding to the 911 call that comes in for somebody who has chest pain or is experiencing headache or has had a car accident or something like that. Sometimes it's about setting ourselves up and doing advanced planning so that when there is a surge in call demand, when there's a change in weather patterns, cold weather and bad weather generates call volumes for us, for an example. Or when we have special events in the community, that we're well positioned to help in those, or to be ready in those events, so that we don't create an unnecessary demand, on our community response paramedics who are out in the community. So we have, in the last year, stood up something called a hazard response team, and that team worked with Waterloo Regional Police, and we'll be working with our fire partners to make sure we can have highly trained paramedics supporting patients in really difficult operational environments. And then the other thing we do is focus on special event and emergency planning. I know we just came off of St. Patrick's Day. Everybody's well aware of what happens at St. Patrick's Day in the community in North Waterloo, for example. And so our teams are on the ground, right, embedded in there to make sure that we can help support the St. Patrick's Day revelers without creating increased demand on our hospital partners. And we think that works very, very well. The other thing that we are really focusing on and is we've seen as a provincial government priority across the province and really supported here, and happy to announce or to share that this community paramedicine is 100% funded by the provincial government. And so we're happy to take that money and deliver really, really great care to the community. But the point to community paramedicine is we believe that over time, our paramedics have developed a really unique skill set to be able to assess people in their homes or where they work, and to be able to support them with chronic health conditions so that they can live at home safely for longer periods of time. And so that role that our community paramedicine play, and they're veteran paramedics who did a lot of years in the 911 side, and now they work in a preventative function upstream to try and focus on supporting people as they age in place before they end up needing to go into a long-term care home or something like that. And we work really closely with REN, Cambridge Memorial Hospital, the KW4 OHT and the other OHTs, and also Ontario Health at Home to support those patients. So essentially, we're kind of a little bit like home care, but we deliver it in a 24/7 environment, which is really, really helpful because we have the operational context to be able to do that. And we do things with REN, for example, as patients are getting discharged with congestive heart failure, they can sometimes join our roster, and then we set them up with remote patient care monitoring while they're at home. And what that allows is for them to be at home, and if we can see through their vital signs remotely that there's been a change, a paramedic can go and assess the patient and make sure that that patient either doesn't need to go to the hospital right away, or maybe they just need a medication change from their primary care physician, so they don't need to go to the hospital at all. So that's one strategy we're doing. The other thing you'll see under alternate care pathways is the province has opened up our standards to allow for different options. I showed you the call volume a couple of slides ago. For context for people, we generally transport about 70% of the 911 calls to local hospitals. And so that shows you if we do 60,000 calls a year and we're hovering around 42 to 43,000 transports per year, that puts a lot of demand on our hospital partners. And some of those patients need to go to the hospital. Absolutely they do. That's where their definitive care will be received. But there's many things our paramedics can do to go assess patients, stabilize them, and then not take them to the hospital at all, but do warm handoff to other healthcare agencies such as either the OHT or CHCKW or different agencies like that, primary care networks. And so We have treat and refer pathways for things like patients with known diabetic conditions and seizure disorders. We have treat and discharge as well for the same thing. And we're focusing right now on helping our system partners set up alternate destination clinics for things like mental health and addictions, because we know that if we can get patients to a community-based alternate destination clinic for mental health and addictions, we know that that is the right avenue for them to receive the really person-centered care they need. And then that will help the system as well, because it also supports emergency department diversion strategies, if that makes sense to everybody. The thing I'm really excited to share with people is come December 3rd of this year, we will be changing our dispatch system. Now, for context for people, we don't actually own our 911 dispatch center. That is owned, operated, and funded by the Ministry of Health. But they are changing the system from the old, and I'm going to say antiquated system of the last 40 or 50 years, which was really a blunt instrument. Someone would call, we would show up right away, lights and sirens, regardless of how sick or acutely ill the person was. And that system resulted in that 70 to 75% of the time, regardless of the reason the person called, we were responding on a lights and sirens basis. The problem with that is if you respond on a lights and sirens basis to call A, if call B comes in and it is a more serious, more acute patient, the system would not allow those paramedics to be reassigned to the more sick or more acute patient. The new system, which is called Medical Priority Dispatching System, that'll be brought into the Cambridge Central Ambulance Communications Center in December, it prioritizes resources for the most acutely ill patients first. So what it will mean is a couple of things. One, the percentage of lights and sirens responses we do, we'll still respond to the calls, but the number that we respond to on a light and sirens basis will probably drop between 25 and 30%. And what that means is that we'll still go to calls, but because those calls are deemed a lower acuity, if a higher acuity call comes in second, then we can reassign those crews to the higher acuity patient, which I would argue is what everybody wants. You want the paramedics to go to the sickest patients or sickest patients always. So we're really excited about this system. It has been implemented in Toronto, Niagara region, Durham region, eastern part of the province, Ottawa, Renfrew County, York region, Halton and Peel with success. And so we're about middle of the pack in terms of implementation. And I know our council colleagues who are here today are very excited about this because we've been talking about this for a number of years. And I joked, when I started in 1995, I was told NPDS would be implemented in the province in the year 2000. And here I am in 2025 and finally seeing it happen. So we're really excited about this coming. What it will mean for service and how we deliver service to the community is we're going to ask our community residents to be aware that, yes, we will come to you when you call 911, but if our system deems that you're not acutely ill, you may have to wait a bit longer so that we can support patients who are acutely ill. And so you're going to see some communications come out from the region of Waterloo and our paramedic services team in particular, designed to kind of let the public know that, hey, this change is coming. The good news about that, though, is the Provincial Dispatch Center will stand up extra communicators who will then call people back on a fairly routine basis every 20 to 30 minutes to make sure that there hasn't been any significant changes. And if there are significant changes, then the call priority will change. And if there aren't significant changes, then the call will still be held in queue. And that only happens if we are at a system capacity issue. So when I started here, we used to call them code reds, which is when no ambulances were available. We've legacied that term. It's no longer code reds. We've actually called it code zeros now. Happy to report we haven't had a code zero a number of months because of the resource improvements we've had. But the goal here is to avoid code zeros from happening to begin with. And so that's where the NPDS system change will do that, because it's going to hold resources back to make sure we always have resources that can respond to our most acutely ill patients, such as cardiac arrests, heart attacks, and things like that. And then the other thing that we will try and do is educate the public about how do you, to use Sarah's term, receive your right care from the right person at the right time. Sometimes people call us and our paramedics function really as early system navigators because people don't know who else to call at 2 o'clock in the morning or on a busy statutory holiday. We're open 24/7 on all those times, and a lot of our healthcare partners are not for different reasons. And so sometimes they don't know how to access healthcare. And so we find our paramedics are really functioning as early system navigators, in addition to providing really high quality care to the community. So And then the last thing I would like to share, which I think is really, really important, and that is the improvements we've seen in this region about ambulance offload times. They've been really, really significant in the last couple of years. And to give you context, the Ministry of Health sets a standard for ambulance offload time from the time the paramedic arrives with the patient at the hospital to transfer of care to hospital staff, is we should be hitting that mark at about 30 minutes on the 90th percentile. What that means is 90% of the time we get in and out within 30 minutes or less. That's what we're supposed to get to. In 2024, from January 1st, 2024 to June 16th, 2024, our 90th percentile ambulance offload time for the Midtown site, now it was 94 minutes. And for the Queens site was 80 minutes, which is really significant. Flash forward 12 months with all the great work that Ren has done in helping us out with this, is we are now sitting at 38 minutes on the Midtown site and 34 minutes on the Queens site. And that is all system. Yes, it is very, very good. And for people to understand what that means, first of all, it's a better patient experience, which is absolutely the most important thing. It means the patients we're transferring care more seamlessly to the hospital experts, and patients are getting better care and more timely care from the whole system, not just from paramedics, but from hospitals as well. But secondly, all that time goes back into our capacity system and our ability to have resources available in the community to respond to subsequent 911 calls. What was happening for a number of years across the province, and I've worked in a lot of different services, is we had paramedics stuck in hallways. You saw about it, it was on the news, it was a real thing, it was happening, and that meant those paramedics couldn't respond to those really acute patients out in the community. Now we can do that, and our paramedics are telling us every day that that's happening in a much more frequent fashion. So we're really, really excited about that, and would like to shout out to the Ren leadership team, to Ron, and to, in particular, Brandon Douglas, the VP of Clinical Services, who oversees both emerges. He's become a real champion for us in this regard, and we're seeing overall system improvement altogether. And then the other shout out goes to, believe it or not, the province of Ontario and the Ministry of Health, because they have supported us with really significant funding to fund designated offload nurse positions in all three emerges. When I started, we only had 12 hours a day per emerge, 7 days a week, and we were able to secure funding 2 years ago, and it's been sustained over time to have a designated offload nurse position funded 24/7. So 24 hours a day, 365 days a year. And what that again means is those nurses are there to take our patients from us if there is an offload delay, which means now we can get back out to the community. So that's a huge, massive improvement. And those are the types of improvements, that partnerships that you heard tonight, that's the fruit that it yields when you have effective partnerships. So that's all I have, and thank you very much for having me today.
Thank you, John. We appreciate the partnership with paramedic services to ensure that the points of transition are smooth for patients. So I'll ask our Ren team to now come up to the stage. I'd like to welcome Sandra Hanmer and Tim Rollins, who are co-chairs of our Ren Board of Directors, and Ron Gagnon, who is Ren's inaugural President and CEO. Welcome.
Thank you, Sarah, and welcome everybody. It's a pleasure to be here. My name is Tim Rollins. I'm the co-chair of the Waterloo Regional Health Network. And prior to Grand River and St. Mary's merging on April 1st, 2025, I was chair of the St. Mary's General Hospital Board of Trustees. I'm going to keep this quick. And Sandra's going to keep it quick, and then it's going to be the Ron show. But what we thought we'd do is just give a bit of the summary of how Ren came about and where we've got to today. And before I go through this, I'm just going to premise everything I say. A big thank you to our staff, our leadership team, the provincial government, our community partners. It has been an incredible journey. It's been incredibly fast-paced, and if you were to ask me 5-6 years ago that I'd be standing here today talking about Ren, it would have been a dream. At that point in time, we were dealing with COVID. We just implemented an ERM system. But through the leadership of this community, through our community partners, through the Region of Waterloo, City of Kitchener, City of Waterloo, Cambridge, everybody, the OHT, we all got behind this. And really it did start prior to 2020. Our hospitals have been working together for over 90 years. And for the past 25, 30 years, we shared a common physician team. But we were looking at our infrastructure, our aging infrastructure. And both hospitals and both boards were thinking about submitting capital infrastructure plans. But thanks to both boards, to Ron, to the CEOs and presidents of St. Mary's, we said, hey, we're not going to be probably successful doing this alone. Maybe it's time to think about putting an infrastructure plan together. Remember, this was during COVID, but both boards, with the support of the management team, said, hey, this community is going to be better off of us coming together with one infrastructure plan than doing it separate. And so that's what we focused on. We spent 2020, 2021, and part of 2022 putting and shaping our plan. We then submitted that plan to the Minister of Health in 2022, and they gave us our initial capital planning grant to proceed and continue to work. And that is when the work really started. And so in 2023 through 2024, significant amount of community consultation took place, planning took place. We had to go look for a site, keep that secret until we could publicly announce it. And throughout this whole process, we really sought the input of all of you in this community, of our partners, about what made most sense. And it was during this adventure, this process, and it was an adventure, there was lots of weaves and turns, that both boards started looking at each other and going, you know what the community's asking? It's asking not just for infrastructure, it's asking for a renewed governance model, a renewed coming together. And that's where we really started focusing with our partners at the St. Joe's Health System about what this could look like going forward. And it was April 2024 where both boards of Grand River and St. Mary's, with the support of the St. Joe's Health Care System, announced that our intention to merge together. And so then throughout the fall, spring, summer, a lot of work was done so we could submit a plan to the Minister of Health in the fall of 2024 with the intention of merging on April 1st, 2025. There was a deliberate intention to that. Hospitals have a year end of March 31st, and it was going to be really much easier if we did this April 1st. Again, a significant amount of work done by our teams, but we got there, we submitted our plan, and we kept working. Yeah, more wrinkles got thrown at us, including a provincial election that we weren't necessarily anticipating. But hey, again, thanks to your leadership, our team's leadership, thanks to this community support, and again, thanks to our provincial partners, we did get approval to merge. And I'll always remember the time, it was 4:57 on March 23rd, 2025. And effective April 1st, we merged our organizations. And so that is where we are today. There is a ton of work still ahead and that the teams are doing. But again, thanks to everybody here, thanks to our partners, thanks to the province, that is where we've got to. So I'm going to turn it over to Sandra now, who's going to speak about what we're focused on now and in the near future. Sandra.
Thanks very much, Tim. It certainly has been a journey, and I can't imagine a better partner than all of the individuals from the Legacy St. Mary's and all of our amazing team at Grand River Hospital who have now made the REN team. I am Sandra Hanmer, and I'm co-chair with Tim, as he mentioned. Prior to REN coming together, I was the chair of Grand River Hospital Board. And I have the privilege of talking a little bit more about the legacy of our organizations. We have our vision, as Tim alluded to, is very well aligned in terms of how we wanted to provide services and make sure that we were delivering the best possible care to the residents in our community. We were able to align easily in this regard and are sharing with you here the interim mission and values set we are working under in this, our transition year. Our mission is to deliver an exceptional healthcare experience with compassion. Our values are our foundation for the care we provide and our commitment to how that care is going to be provided. Care and compassion. We bring our best every day to deliver high quality, safe, and see the person treating everyone with empathy and compassion. Trust and respect and integrity. We keep our word, we trust others, and commit to transparency, consistency, and continual improvement. Innovation and courage. We have the courage to innovate and continuously raise the bar and inspire curiosity, inquiry, and discovery. We never stop learning and teaching. Tim talked about how much it is important to us to have community input. Equally, it's important to have the input of all of our staff team as we continue to grow and work together. And finally, our fourth value is to welcome inclusion and collaboration. We value our individual differences and interests that integrate the different perspectives into everything we do. We welcome and respect the diversity of our patients, team members, and partners, and are committed to equitable treatment and elimination of discrimination in all its forms. This is how we operate, this is how we make our decisions, and this is how we provide care to you. Where we care for you doesn't change. And I'm going to turn it over to Ron to explain now where you can receive the services and what's on tap next. Ron.
Thanks, Sandra, and thanks, Tim. Appreciate your leadership and the introduction tonight. And well, this computer says it's going to restart. So all right, so want to make time for questions because that's really the most important part of this evening is to hear from you and answer your questions. So I'm going to move at a pace that hopefully does justice to the slides, but also gives us the amount of time that we need. So as Sandra said, where you receive care doesn't change, and we have three main campuses at the Waterloo Regional Health Network, 2 emergency rooms in those campuses, one at our Queens Boulevard site, what you formerly known as St. Mary's, and one at our Midtown site, which you formerly known as our KW site. And we also provide much needed care at our Chicopee site. And on the next slide, a little bit more detail. I'm not going to go into all of this detail, but I'm going to start at our Chicopee site where we provide some really important services in complex continuing care and rehabilitative care. We also provide breast screening at that site, and we provide specialized mental health services at that site. So though we provide more than that there, but those are the things that I would highlight at that site. Our Midtown site is the home of our regional cancer program, of our regional renal program, of our regional stroke program. We also provide childbirth services and mental health services at that site, which are quite specific and unique to that site. At our Queens Boulevard site, it is the home of our regional cardiac program, our regional eye program, and as well as our regional chest program, as well as a number of other services that you would see there. Some of the services that we provide at both our Midtown and our Queens Boulevard site, surgery as an example, medical services as an example. And in addition to that, we have a number of community-based services and locations, not just in the region of Waterloo, but in the broader Wellington region as well. And probably the most important numbers on this slide, and of all of my slides, are these 7,000, 700, 700, and 900. These are the people of Wren. These are who Wren is, right? I'm going to talk about our facilities that we're planning, the services that we're planning. All those things are fantastic, but it's these people that bring our organization to life. And so part of what we're really focused on as we go through the next year or so is going from our fantastic legacy organizations to bring the best of both of those to REN to create that one organization, that one culture, that one experience that will really go above and beyond every single time. And then the numbers below give you a sense of how big we are. We are one of the largest community hospitals in the province now. You can see our total emergency room visits, approaching 150,000 a year through the efforts that both the OHT and our regional paramedic services. Hopefully those will go down, and that'll be fantastic for our community. In addition to that, we've got almost 40,000 people who are admitted to our hospitals every year, and for the accountants in the room, the people that like finances, we're just over $900 million now in total revenue. So a very sizable community hospital in this province, which only goes to benefit the community that we serve. So this year, on this slide, what you see is our three key priorities. We like to think in threes. What are those big threes? So with a key focus on our patients, our first priority is high quality and expanded clinical services. So 3 examples around high quality that when we talk about: reducing emergency room wait times, reducing surgical wait times, and improving our already great results when it comes to harm in our hospital. Any harm is one harm too many, so we're continuously focusing on that. When we talk about expansion of those services, some of the key ones that we think about are bringing the first ever PET scanner to this region, bringing neurosurgery back to this region, and adding a third cardiac catheterization suite so that we can continue to provide that high quality care right here close to home. We're also looking at merger success as one of our key priorities, and this is really about becoming one. I'd like to say that merger is a one-day thing. That was April 1st. Integration, which is the bringing together of those two legacy organizations into one strong, unique REN organization, will take years. And we're focused on getting that right and doing that right. And another part of Sarah's role is leading that work for us as we go through transition. So that's fantastic. And then redevelopment progress is something that we don't want to let up on. You heard Tim talking about, even during COVID, we made the decision that we needed to do something about redevelopment, about modernizing, expanding, and building new healthcare infrastructure, because we need to be able to serve a rapidly growing community. And to use Chair Redmond's words, we need to be 1 million ready. So that's what that is about. So let me quickly talk through our multi-year, and it is really 2 decades worth of facility renewal, facility building, and facility expansion across all of our sites. And I think we've already spoken to this, but this is really, this slide speaks to why did we do this together, right? And it is really about all of the points you see here. The bottom line is an improved service for those that we care for and care with, and those that provide that care to them. And that's really our focus. So our master plan has 3 key components. Our first step is building that new hospital at the university. And we're focused there on 2034, 2035 opening of the second phase of a 3-phase project. Our second step is expanding our Chicopee site, and that's over up until about 2038. And that includes the addition of new services, new beds, and brand new infrastructure as well. And renovating our Midtown site over that same period of time, probably stretching into 2035 as the first phase, the second phase completing in or around 2035 to 2045. And also our third phase of building that new hospital at the university site. So some might say, well, why phases? When it's all said and done, that new hospital will be 2.6 million square feet. And unless we do it in phases, we won't have a construction market who is willing to build a facility that big all at once. So we needed to phase it in a way that we would be able to get actual competition from the market, interest in the market to build facilities that are much needed in this community. And that's why it's phased into 3 phases and done in a way that doesn't jeopardize high quality patient care. So this gives you a sense of the sites. It's a beautiful site. It's a large site. It's over 60 acres, and it will quickly get built up. And, I think Tim really walked through a lot of this already. The point of this slide and this next slide is because of the urgency and the importance of building capacity to meet the growing needs of our community, we're moving at a pretty rapid pace. We started during COVID. We got our first capital planning grant. A month later, we submitted the plan for which that money was given to us. And that was because we had started our planning ahead of time. We were investing in this community, to be ready. So the most recent $10 million planning grant that we just got, we're actually submitting the plan that was to fund this week. And we will continue our planning in that fashion so that we're working alongside with the Ministry of Health and Infrastructure Ontario to meet their needs so that we can meet the community's needs and continue to move at a fairly rapid pace. And the other thing that I'm very proud of is the support that we've received from the province. You will recall when we were announcing the site, we had, I think it was 4 cabinet ministers and the premier here. That doesn't happen just by happenstance. That happens because the province is indicating its support for the project that they're coming out for. So that is great to see. So what's ahead for us is we're starting our next phase of planning now. And that's referred to as phase 2, which is a lot of the more detailed planning, getting ready to go out to the market in probably the 2026, 2027 fiscal year, so that we can open the first phase of our project by 2032, the second phase by 2034, 2035. And that's where we're heading. This gives you a sense of what that site will look like come 2039-ish. So you have in the gold color, if my eyes aren't failing me, that's phase 1A and 1B. And then in the blue is that phase 1C, which is the last phase of the project. And that's all on the new hospital site. And this gives you probably a more architect, and Cliff Harvey, who's our fantastic VP of redevelopment, is an architect by trade, loves the technical. And I will tell you, our community is extremely lucky that we were able to attract Cliff to our project. I would say he is probably the best available for this type of project in this province for sure, if not this country. So we are well served by Cliff and his team. So this gives you a sense of what we're looking at in the timeframes that I talked about: 2032 opening of 1A, 2035 opening of 1B. And okay, on this slide, what you see here is some of the early work that's going to happen. You're going to start to see some activity on the site, starting to clear the site in 2035, more active work in 2036 as we continue to move the project forward. And this is all intended to be able to move the project at a pace so that this community is well served, so that we can be that 1 million ready that we're all aiming for. And as you came in tonight, as you were invited to this, you probably saw and read about, that one of the big things that we're doing this year is that inaugural strategic plan for the organization. So we're asking for your input around some key questions. Please go to our website. Please go to the table tonight and answer the questions that we have for you. There'll be some follow-up as well, because what we're trying to do is shape where do we want to be when that first phase opens. So about a decade out, where do we want to be as a community? So as phase 2 opens. So it's looking out a decade. What's that vision for our community, for our organization? Setting our values, setting our mission, and setting our first steps down that road through the key strategies. And that is really one of the key pieces of work that we'll be doing as an organization this year, because I will tell you, a lot of the strategies of the two organizations that predate us brought us to this point. And so strategy is important. And we need your voice, we need your input on the direction we will take. So with that, I think I'm turning it back to Sarah.
That's great.
Thank you, Ron. So we get to hear from you now. We're excited to engage in conversation. We've got about 25 minutes to do that. We have the ability to ask questions both online and here in person. So we'll invite Ron and Tim and Sandra and John and Ashner up to the stage. We've got some chairs for them to settle into. Okay. And for those of you that have already figured out our Slido platform or are used to that platform, there is the ability to both watch the video and ask questions on the platform. So please go ahead and do so. You can do that by visiting slido.com and entering the code #community-townhall or scan this QR code. You should be able to hold your phone right up to your screen and then go ahead and ask questions that way. Audience members, also feel free to ask questions that way if you're a little bit nervous to speak, because we do want to hear from you. And then in person, if we have folks raise their hand, we'll bring a mic to you. And for those that are joining online, I'll be sure that I repeat the question so you can hear what's been asked. So while we are peeking for hands, and I can't see because the light is so bright, we did have one question come in already online, so I'll ask it to the panelists. What will you do to make sure that patients aren't yo-yoed back and forth between the hospital sites, to home, or to long-term care?
Happy to start, but I think both Ashna and John can probably provide even more insight than I can. I think it's fair to say that we're lucky to be an active partner in the KW4OHT, and that's really at the heart of it. Right? So how do we have one integrated system? How do we have one integrated course of care for people? How do we make it clear on where they're able to go for that care? I think some of what John was sharing earlier as well gives you an indication of how we're all thinking differently about how care can be provided. Keeping people healthy first, caring for them in their home. One of the things that we're starting to talk about inside of our walls is making sure care is delivered at the point of need, not at the point of care, which is usually what people, the way we've thought about healthcare traditionally. So I'm going to turn it over to these two because I think they probably have way more than I do to say.
Not so sure about that, but thank you for the question. I think from our context, it's important that in the 911 response context is that we effectively triage and identify what the care needs are for the patient. And so then when and if we have to transport them to the hospital, we're transporting them to the right location the first time. And you see that already occurring in the Waterloo region with some of our what we call STEMI bypass, or for heart attacks, we transport directly to the Queen's site and take patients directly to the cath lab. So that's definitive care the first time, the right time. Stroke care is another example of the Midtown site. And then the other thing that we're really focusing on is how do we support other underserved populations, for example, patients who are on palliative care rosters. We now have an alternate destination protocol in which people can call 911 if they meet certain criteria. We transport them directly to local hospice. We bypass the hospital altogether. And so they continue to get care from the palliative care team. So those are examples of how that works. I think the other thing is the community care medicine lens in our context is really, really important. How do we keep people healthy at home for longer? And then only transport them to the hospital when we need to Ron's point, rather than just default transporting them to the hospital is kind of our strategic goal.
Thanks. Thank you so much. I would add just a couple of other comments. One of them is that although, we talk so much about the physical hospital build, the opportunity to really partner with primary care or community agencies that are also serving many of the same community members, and to do that in an integrated way so that it doesn't matter that you're not at the hospital, the connectivity between the hospital and those that are serving in the community is there. So we have a seamless system. So if someone in the community like John, his paramedics is picking someone up, how do they know it's already happened? How do they have access to the health records of that individual so that they can provide the best possible care? And how can they ensure that they can connect into the hospital? so that they don't necessarily have to go into the hospital with the patient, but that they have access to many of the questions that they need to answer so that care can be provided, as Ron said, at the point where it needs to be provided.
Thank you. We're gonna go to the community next, and then I'll repeat the question.
Hello, great to development and John, I was really impressed with the progress of the paramedics. And I'm just curious in how you handle the crossover between the fire department and the paramedic services, and where is that line between dual calls and how does that get managed?
So the question from the audience was about how fire and paramedic services collaborate on calls.
Thank you very much for your question. That's a really interesting question because it speaks about the actual 911 response, and it's commonly called in our vernacular tiered response. So certain calls get sometimes police, paramedics, and fire all responding. And one of the things that myself and Chief Crowell and all the fire chiefs are committed to doing is to right size that response. There are times when all three levels of emergency services do need to be at a call. A car accident with leaking fluids or fire, for example, you need all three agencies there. Us to do the patient care, fire to stabilize the scene, and police to keep it safe, as an example. But there are other calls that maybe not all are needed. And so one of the things that this new NPDS dispatch system has triggered us to do is to meet with all our fire department partners and right size our tiered response agreements. That is still a work in progress, but we're learning from other jurisdictions. The other thing I would say is we have a really strong relationship with our fire departments, and they understand their role and how they can support us in doing our role really effectively. I have a son who's a firefighter, so I'm acutely aware of this, and he wants to go to the right calls for the right reasons as well, and he doesn't want to go to the calls where he wasn't able to affect any improvement anyways, right? So that's a work in progress, but I would say that when something really significant happens in the community, you do need all three agencies to respond because we all have very unique roles in what we provide to the patients that call 911. Thank you.
Thank you for the question, and thanks, John. We'll take one from online now. With the removal of mandatory masks at the hospital, how does REN protect immunocompromised people? So I think that's a question for Ron.
That is probably a question that I might ask Liz to come up and help answer. We continue to be a mask-friendly organization, so if people choose to wear masks, we would encourage them to do that. And we have staff that wear masks, we have physicians that wear masks, we have patients and family members who continue to wear masks, and we make them available. And in addition to that, if someone is immunocompromised, and we're aware of that, we will take special measures to make sure that they get the protections that they need.
Go to the audience again. We've got another one.
Hi, thank you for being here. I have a question regarding primary care access. How are you utilizing nurse practitioners or physician's assistants? Because not a lot of people are educated on what they do. People hear nurse and they say, absolutely not, I want to see a doctor. And most of the time people don't need to see a doctor. So how are you utilizing those to alleviate the backlog in the primary care space?
So the question is going to Ashnar, and it's about primary care capacity and how we can leverage physician assistants and nurse practitioners and some amazing providers to really expand that primary care capacity.
Thanks so much for the question. It's a great question. And I have to say that in our region, we actually have one of the few nurse practitioner-led clinics, and it's an outstanding organization that provides incredible care for very complex patients. So we, in our region, can demonstrate quite effectively the value of nurse practitioners with respect to managing primary care, or with respect to managing complex patients. And we can do that through the data, for example, to understand just how complex those clients are and how they compare to other primary care providers' patient caseload. So one is education and awareness. Also in our geography, we've been working very closely with our nurse practitioner-led clinic, our community health centers, and our other primary care models to really look at what does team-based care mean and how do we work to our full scope of practice within team-based care. As the province continues to emphasize the importance of primary care attachment, we do not have enough physicians if you will, nor is it just about physicians. It's about ensuring that the nurses, the physician's assistants, the nurse practitioners have the ability to work to their full scope so that we can allow more patients to be seen by physicians when they need to be seen by physicians. But there might be a time where you need to see the pharmacist, quite frankly, or the dietitian or the physiotherapist. And part of the model that Ontario is trying to introduce is really that approach to team-based care, where individuals can see the most appropriate practitioner as part of an integrated team. Thanks.
Thank you, great question. We've got another one that I think probably anybody could respond to, and it's about artificial intelligence, a hot topic these days. How are privacy concerns being addressed as we start to see more AI in primary care offices, in hospital, perhaps in paramedic services? So who would like to start? There you go.
I think it's a great question in this day and age for sure. AI is definitely one of those, I refer to it as the next step change type of opportunity for us in healthcare. So, I know in our organization, we're considering that as we work through what is our AI strategy. We have a team, a multidisciplinary team right now actually working through that strategy, and privacy and security of data and information is one of the key aspects that's part of it. So we're going to address that through policy, through the way we set up systems, through the way we set up structures. But one thing for sure, we are going to capitalize on the opportunity that is artificial intelligence, and generative artificial intelligence in particular, because it does offer, the way I've talked with friends at times is, I'm old enough to remember the dawning of the internet, and people saying, it's never going to do anything. I think we're in that same era, so we do have to take that responsibility of how do we use it in a safe, effective way to deliver the maximum value for the people who need it. And that's, I almost said patients, but it's not just patients. It can be a core component of chronic disease management that we're talking about, of self-care, of keeping people well. It has all kinds of opportunity for us as we go forward. And it will also help us bridge that gap of the resources we need for healthcare and the resources we have when it comes to human beings.
I would just add that in our context, there's a lot of research going on in the paramedic profession and in systems level research about how do we use AI to better dispatch and triage the 911 calls that come in. And so in the context of the question related to privacy, any level of technology you use in a digital strategy requires privacy frameworks around it to support individual privacy and also the privacy of patients and people that call 911. There's a lot of exciting research in our sector related to dispatch. Also, there's AI tools to support paramedics making clinical decisions in the field is really, really important to us because our paramedics don't have the benefit of looking at x-rays or blood work or ultrasounds and stuff to help make a determination what medication they can give, but AI can really help in that context. So that's kind of probably the next phase of evolution for our sector in particular.
We'll keep moving out in the audience. We are going to go for about 10 more minutes. We're going to take this till 8:40 and then the library will close on us. But we did want to, there's been such great engagement. I think we've got a couple more questions in the audience and a couple more coming online. So we'll go till 8:40. Please go ahead.
My question is in regards to why at this earliest stage was there a need to change all 3 days of the 3 locations, which just makes it confusing, especially when a lot of these facilities are more aged population that are using them. Certainly if we're looking at fundraising or anything like that, it seems like there's an added cost to rename all of these locations when ultimately there's going to be a new facility 10 years down the road. Just wondering why there was a need to rename all these locations. I think it's very confusing and it could throw off your fundraising as well.
Okay, so for those joining online, the question was for our REN leaders here about the site name changes. Why was that needed? And perhaps some concern about confusion in the public and impact on fundraising.
Just hand it back to you, sir. So it's a great question. I appreciate the question. I appreciate the sentiment as well that came with it. it is not a decision that was reached lightly. We went through a pretty detailed process about the need to change, and what we knew is for the former St. Mary's site, we could no longer continue to use that name because it is not owned by the community. It's actually owned by the St. Joe's Health System. So we knew that we were going to change that. That gave us an opportunity to think about how do we create one RAN organization as opposed to living with the legacy of organization names. We did consider the cost, we did consider the confusion. We're trying to do, and I think we're doing a reasonable job of making sure people are clear on where to go. On the fundraising, our foundations just recently came together. They continue to raise funds for the Waterloo Regional Health Network. And as we get feedback on the information that we need to get out there, we will continue to do that. But at the heart of it, it's really trying to create that one organization, that one new organization, and creating that and demonstrating that for the community.
Thanks, Ron. So we'll actually ask Ashner and John to team up on the next question. There's a theme about sort of smaller community agencies and how they are a part of the broader healthcare system. So a question specifically, John, for you about after a paramedic assessment, how is that connection made to a smaller community agency? And then Ashner, maybe how does that community agency fit in the bigger system?
Thanks for the question. In our context, it's kind of done in a few different ways. One is we do have referral pathways to, for example, CMHA Waterloo Wellington, through Here 24/7 and things like that in the context of providing mental health supports. Also, we do referrals, as I already mentioned, to palliative care teams and work very closely with palliative care teams supporting palliative patients in the community. And then what we're working on, and is still a work in progress, although I think we do a decent job, is internal referrals from our 911 response paramedics to our community paramedicine team is a really important linchpin, because it's our 911 paramedics who sometimes see the same patient in the same number, like they can see the same patient 2 or 3 times in a set of 3 or 4 shifts, and that tells us that that patient is probably not getting the support they need from a system. And so when that happens, they refer to the community paramedics, who then follow up with the patient in a non-emergency fashion and then connect them to referral pathways to the proper community agencies, any one of them from primary care teams to, mental health supports and other community partners like Thresholds and things like that. So that's how we do it. We need to digitalize that in a digital strategy to make it a bit more easier on our frontline providers to do it. But if I don't know a single paramedic who's not resourceful when they know the patient needs something, so they find a way to make the referral happen, but we need to make it simpler for them for sure.
Thanks. And thanks for the question. It's actually a really interesting question, and I'd like to answer it using 2 different examples, if I may. The first one is the OHT was very successful in securing funding related to what the province was calling the Black Health Initiative. And that was really to recognizing that those individuals who identify as Black often receive different care than those who did not identify as Black. And we were able to secure funding in the community with Community Health Caring, CHC, as well as with REM through our SCOPE program for additional dollars to really look at this more carefully. So with the hospital, we were actually trying to understand those physicians and primary care providers in the community who worked with the Black community, what were the challenges that they were having in accessing specialists? And what types of specialists were they trying to access specifically for the Black community? For the CHC, the work was related to youth mental health and determining what were some of the issues that Black youth were facing and how could community supports and primary care really support them better, working with also police services. The truth is that in order to really do that work, we needed to connect with the Black community. And that really spoke to the small grassroots agencies who were connected, who have trustful relationships with Black youth or with the Black community. So if we really are interested in changing the healthcare system and taking an equitable approach, we need to go where people feel safe. So whether it's the Indigenous population or the Black community or the Francophone community, it's very difficult when you're having large scale engagements to really hear from many of our marginalized communities or more vulnerable communities, because we don't always unintentionally, really create space for them to be heard. So by working with our small grassroots agencies, we can ensure that their voices are also part of the solution and decision-making that we have. The second example I want to give is related to our rural community, and this is very important because in the KW4, in the Waterloo region, we have about 20% of our community living in the rural community. And oftentimes we look at numbers or of an agency to determine its size and value. The truth is that given the space, many community agencies cannot see the same number of clients in the rural community as they might see in our urban communities. But that doesn't mean that those individuals in the rural community don't need those services just as much. So it's really important when we look at how to measure value that we take different aspects of the population and the geography into our considerations, because those small rural community providers are very connected and understand what's happening in the Mennonite community or in other geographies. And it's that knowledge that makes us better healthcare providers. Thanks.
We'll take our last question from the floor here.
Hi, thanks for the work that you do. Quick question, like, is Red working towards like making themselves a bit more resilient towards like shifting economic priorities, like, you know, like in terms of funding or maintain quality in case something happens, like an emergency or whatever?
Thank you for the question. So for those joining us online, the question was about resiliency in RED, and I think you could probably ask any health service provider this question. With government funding, with the potential of another pandemic, what resiliency is built in to our services to make sure that we can continue providing stable care to the community. So who would like to start?
Yeah, I think it's a really insightful question, and thank you for it. I'd like to say that we have all the redundant capacity that we need to be ready for the next pandemic. That is what we're working towards for sure. The reality is, on any given day this past winter, we were operating at 130% capacity across our two main camps, actually across all three campuses. And to put that into context, that's after having added 200 beds and the people that go with that since the beginning of the COVID-19 outbreak. So the way we're trying to create resiliency now is through our work with the KW4OHT, through our work with the paramedics, through our work with other partners to look for different approaches to the delivery of care so that we're not consuming all the resources in the hospital and therefore not having that ability to be resilient in those times. So that's what I'll call the care side of it. The other side of it is how do we build resiliency in our own team members, and I think we all face this. And this is an area that we are looking to invest in. We invest already in a team member wellness program. We are exploring how we could augment that even more, because it is the resilience of our people that will make the biggest difference in the next pandemic.
I would just add, in the paramedic services context, resiliency is front and center for all of our team members. Our paramedics see and deal with really challenging operational environments that affects them. They're human beings and they want to give great care, and sometimes there are structural barriers that can prevent that. And so one of the things that I'm particularly proud of at the Regional Waterloo is our council-supported mental health strategy for paramedic services. We have a robust peer support program that is paramedics taking care of paramedics that receive really kind of bang-up training from a local agency, Breakwater Institute in Cambridge. And our Growing with Care strategic plan, one of the 4 anchoring pillars of it is resilient and future-ready organization. So it's like baked into everything we do about how we build our organization, how we expand with a fiscal framework in mind, but still expand to meet service demand. And then more importantly, and where we get real great wins is the partnerships Ron mentioned. The cost, if you will, to fix ambulance offload times was just people focusing on partnering together and building systems in place to do it. And that didn't actually cost more money or cost more healthcare positions to actually deliver it. It actually was us getting together and going, okay, what's the strategy? What's our target? And how do we get there? And so we found a really great efficiency just from working together. And so that's a really great example, but I could list many more that would take us way past the end of the NHL game.
And I realized I didn't keep my commitment to keep you all up to date on the score, so. Sorry?
It's 1-0 Florida.
Okay, 1-0 Florida. Some of us may be happy about that and others may not. Okay, well, if you don't feel your question's been answered, please send us an email at info@ren.ca. We will make sure it gets to the right person. We will make sure your question gets answered. Thank you for your engagement tonight. Same goes for those in the audience here. Please, if you'd like to grab a couple of minutes with any of our panelists or our team members in the audience, please do so. Thank you to our panelists. We have a little bit of Ren swag here for you to thank you for being here tonight. It was great to do it in partnership this time, and we hope everybody travels safe home. Thanks, everybody.